Thank you for this opportunity to talk to you about the laboratory evaluation of hypo and hyperthyroidism. My name is Peter Graham and I work at the University of Nottingham in the United Kingdom. So let's start with hypothyroidism. And just a quick reminder that we're dealing with an endocrine system that is based on a pituitary gland producing thyrotropin, otherwise known as TSH, which stimulates thyroid hormones to be produced by the thyroid glands and which exert a negative feedback effect on that pituitary production of TSH. For hypothyroidism, we're mainly thinking about this as a condition in dogs. And some animals will be very clearly hypothyroid, or the distinction will be an easy one to make. So one of these animals is hypothyroid and one is not. Hopefully, for most of you, that would be an easy call to make. But we have a tragic facial expression, we have body weight gain, we have superficial pyodermas, we have some loss of hair. A particularly classic place for hypothyroid dogs to lose some hair is here on the dorsum of the nose. We might have superficial pyoderma, we might have deep or recurrent pyoderma as a clue that this animal needs investigating for thyroid disease. I think there's a couple of things that are worth thinking about. I'm not sure if maybe this is a condition that isn't maybe overdiagnosed. Partly that's to do with the poor diagnostic specificity of total T4, which we'll talk about shortly. And also because of something called thyroid hormone responsiveness. But at the same time, perhaps it's an underdiagnosed condition. So more than once in my career, I've come across laboratory results that are really very dramatically in support of hypothyroidism in dogs that show very few clinical signs. So perhaps there's more hypothyroidism out there than we recognize. And also I share with you some very old, well, not very old, but pretty old data where animals were made hypothyroid experimentally, and it took a very long time for it to be really obvious that they had hypothyroidism clinically. So this slide touches a little bit on thyroid responsiveness. For many years, I've been contacted by breed organizations who have told me that they thought their breeds might have a thyroid problem, that many animals in their breed, in their dog breed, seem to have hypothyroidism. And they were basing that on the observation that many dogs were receiving thyroid medication and that they were doing quite well in the shows when they did, or doing better in shows when they did. However, when we would look at our laboratory diagnostic records, we would often discover that the breeds that was most concern about weren't breeds that we actually saw very much true hypothyroidism in. This study by some colleagues at Michigan State University quite some time ago now, was really quite eye-opening. And this is some skin biopsies looking at hair follicles from dogs, where instead of cutting from the top to the bottom of the skin layers, they've cut parallel to the surface so they could really look at the hair follicles. And these would be normal hair follicles with a single primary, or guard hair with some secondary hair follicles around about. So this would be what might be described as the top coat, comes from these primary hairs, and then the softer, thicker undercoat comes from these secondary follicles. And dogs with hypothyroidism, certainly they've got less follicles, and in particular, they've got smaller and fewer secondary follicles. So we lose that undercoat, particularly in hypothyroidism. But what was apparent in dogs that were being given thyroid medication is that in dogs with thyroid medication, we had thicker, bigger, perhaps maybe an increase in number, but certainly an increase in diameter of these secondary hair follicles compared to normal. And then that suddenly all made sense with these dog breeders that were telling us that animals that went onto thyroid medication had better coats and were doing better than in shows. But actually, they didn't have hypothyroidism. They were benefiting from this thyroxine responsiveness, the body's response to those increased thyroid hormone concentrations included an increased quality of secondary hair coat. So we just have to remember that thyroxine is a potent pharmaceutical agent. It's used very frequently and without always very much consideration, because it's considered to have a low toxicity and not to give us many side effects. But there are some non-thyroidal illnesses which will demonstrate some kind of response to thyroid medication. That doesn't mean the animal's hypothyroid. It means that whatever is wrong with it, does have some mechanism by which it's going to respond or improve with thyroid hormone. So alopecia and hair coat quality would particularly be one that we've got good evidence for. I think recognizing that there might be some circumstances where thyroid therapy does improve an animal's condition, even though they don't have hypothyroidism, may mean that there are legitimate reasons why thyroid hormone might be used in that way. But if it is, then it doesn't necessarily need to be lifelong therapy, because the animals don't have destroyed thyroid glands, or using it in a therapeutic way. Maybe the way that we would think about how we use glucocorticoids in animals, we don't use glucocorticoids in animals because they all have hypoadrenocorticism. We use glucocorticoids in animals because we get a pharmaceutical effect from those, that we use them temporarily. And there may be some justification for some circumstances where thyroxine could be used in a similar way. And here's the extract from that paper that talked about the duration of time it took from an animal being made hypothyroid before the clinical signs, the obvious clinical signs, became apparent. So I think it's possible that whilst we might be seeing overdiagnosis, we might also be seeing underdiagnosis of hypothyroidism in dogs. So let's start looking at the laboratory evaluation, and let's start with the place that most people do start, which is the measurement of thyroxine, otherwise known as T4. It's a relatively straightforward molecule. It's formed by two tyrosine residues coming together within the thyroglobulin molecule. So it's not a big molecule, it's not very complicated. The advantages to measuring thyroid hormone, thyroxine, is that it's easily available. There's lots of different ways to measure it, and it's quite inexpensive to get done. It's important that we use veterinary technologies or veterinary labs to do it, and that's because the human normal levels of thyroid hormones are very much higher than those in dogs and cats, or in dogs in particular, and so we need to be able to measure lower concentrations than is typically possible with an assay that's designed for human use. Some of the downsides are that thyroid hormone might be low in non-thyroidal illness, or when animals are on certain concurrent medications. We might therefore see a high false positive rate for hypothyroidism, because there's other reasons that might make thyroid hormone low, like being unwell. And being unwell is why many animals come to veterinary surgeries in the first place. So having a low thyroid hormone concentration in isolation could be hypothyroidism, but actually more likely, given the population that we see in veterinary practices, could just as likely or more likely be that they're just unwell for some other reason. We'll talk about thyroid hormone antibodies in a moment, and they can cause some false negative results in some setups, but they can also cause some sort of false positives too. Not all hyperthyroid cats, again, we'll talk about this a bit later, will have high total T4s. And some breeds of dog, the sighthound breeds like greyhounds and Salukis, naturally have much lower levels of thyroid hormone than other dog breeds, and so sometimes they are diagnosed as hypothyroid when they just have thyroid hormone concentrations that are typical for those breeds. It's important that we recognize where the lab result is coming from, and the fact that lab results and the quality of lab results can vary. And it's important that you get to know and understand the method that you're using for thyroid hormone analysis. So for example, these are some results must be quite old results for only about 30 labs measuring thyroid hormone around the world. We've sent a sample to around 30 labs around the world, and they've sent their results back. And we can see there's a range of results being generated by these different methodologies. So trying to use textbook cutoff values to diagnose thyroid disease is problematic if different labs are generating different results. Here's some results from a study that one of our students did comparing total T4 measurement using a reference laboratory piece of equipment or using an in-clinic lateral flow snap type device. And we can see there each of these points here represents a different sample. So this is one sample and the two different results, the commercial lab and the in-clinic lab. Quite a difference here at the higher concentration, and not such a difference down at the lower concentrations. So possibly these might perform similarly when we're trying to diagnose hypothyroidism, and this kind of concentration level. There's not a huge amount of difference between those two different measurement techniques. But if we're monitoring thyroid hormone therapy, again, which we'll talk about later, we could get quite different results. So that's looking at total T4. Let's think about some of the other thyroid tests. We'll spend some time talking about thyroglobulin autoantibodies, free T4, and TSH. I'm not going to spend much time in this presentation talking about T3. So this is a summary slide. We'll come back to this a few times in this presentation. And it just gives us some diagnostic sensitivity and specificity information for some of these tests: total T4, free T4, TSH, a ratio of those, and thyroglobulin antibody. And total T4 has been reported to have very high diagnostic sensitivity, meaning we'll get low numbers of false negatives. If we get low numbers of false negatives, we can rule out disease easily. So a normal total T4 generally is very supportive that hypothyroidism is not present. Whereas for specificity, we get much lower numbers. That is, there are lots of other reasons why animals would have low T4 that are not hypothyroidism. TSH is kind of the reverse. We've got pretty good specificity for TSH. When we have high TSH, it usually is hypothyroidism. But if we've got, there would be hypothyroid dogs which don't have high TSH. We'll talk about TSH again more. So if we use kind of panels of results here, like total T4, TSH, and thyroglobulin antibody panel, we can, in certain circumstances, given these sensitivities and specificities, be confident in our diagnosis. We'll talk more in detail about each of these tests in turn, but just in terms of a summary, because of that diagnostic sensitivity of total T4, there would be some hypothyroid dogs that could have a normal T4. But our biggest problem with total T4 is that maybe up to a quarter of dogs that don't have hypothyroidism but have something else wrong with them will have a low T4 level. Free T4 by dialysis, on the other hand, a low number of dogs with that non-thyroidal illness will have free T4 results below the reference range. So this is like 10% being compared to that 25%. So it's an improvement. It's better. It's less likely to give a false positive result for hypothyroidism. And TSH, I've said, seldom high unless there's thyroid dysfunction. That fits with the higher specificity. But we have this problem where, because TSH isn't perfectly sensitive, we will have circumstances where we've got a normal TSH result and a low T4, and we can't tell if that animal's got a non-thyroidal illness which is causing the low T4, or if it's one of that proportion of hypothyroid dogs that have normal TSH levels. But we could add thyroglobulin antibody to that group, because that's positive in about 50% of hypothyroid dogs, and if that comes back negative, hypothyroidism is much less likely. So just an example of this non-thyroidal illness concept. Here's a Doberman which had been hit by a vehicle. I think that was the explanation in this case. And it had blood samples taken. There was a hematoma, and the animal seemed to be bleeding, and some concern that it had a bleeding disorder, which in a Doberman could be something like von Willebrand's disease. Historically, there's been a bit of a connection maybe between hypothyroidism and von Willebrand's disease, but I think now that's been pretty categorically determined that it just happened that both of those conditions were common in some breeds like Dobermans. So when we look at the set of laboratory results, we have a very low total T4 and a normal TSH. So this could be this Doberman, because of its other condition, this vehicle impact, has just got lower T4 because it's this other illness. Or it could be one of a proportion of hypothyroid dogs in which TSH is not high. Thyroglobulin antibody is negative, which pushes us a little bit more towards it being a non-thyroidal illness. So in July, this is its lab results. So the veterinarian quite sensibly didn't start thyroid medication and just waited and retested the animal next month. And without any thyroid medication, I was able to document that the animal was not hypothyroid. And so sometimes that's a possibility as well, is to consider retesting animals after any identified non-thyroidal illnesses have had time to resolve or improve or have been treated specifically by a therapeutic approach. So when we're talking about genuine hypothyroidism, how do animals become hypothyroid? Well, we think the pathology runs along this kind of pathway. So if we look at histology of normal thyroid glands with these thyroid follicles, this is a higher magnification slide than the others, but these other ones are all the same magnification. Anyway, there's variable magnifications in these slides, but we can see that we've got follicles with a thin rim of a cuboidal shaped thyroid follicular cells. The first stage in the pathologic process is the infiltration of little pockets, little islands of lymphoplasmacytic inflammation. And you could imagine in this thyroid gland, with these little pockets of inflammation, yes, there's inflammation there, but there's really no impact on function because almost all of the rest of the thyroid gland is perfectly healthy, able to make T4 and respond to TSH. But what can happen as this pathology spreads and takes over more of the thyroid tissue is we start then to get to a position where the thyroid gland can't make thyroid hormone so well. The pituitary senses that, it starts putting out more TSH to try and drive what's left of the thyroid gland to work harder. And what we can see is that the thyroid gland does that. The epithelial lining of the follicles becomes much more tall and cuboidal instead of the low, much more tall and columnar. Eventually, this pathology gets so extreme that it takes over completely. All the thyroid follicles are destroyed, and we don't have functional thyroid anymore. So we go through this process here. This animal will have normal T4 and TSH concentrations. This animal will have high TSH concentrations driving this extra production of T4. And if it's successful, then T4 might be normal. So this could be high TSH and normal T4. And then in this situation, T4 can't be made. And so we've got high TSH and low T4. And we wonder if that eventually, when there's no thyroid antigen present anymore, this inflammation eventually is going to die down. And that maybe is what we end up with when we split the pathogenesis of hypothyroidism. Historically, that's been split into thyroiditis, which is this process, and idiopathic atrophic condition, where we didn't really know what was causing it, but all that's left is some fibrous tissue and some adipocytes. And when we look at the age profiles of these different categories of disease, if we look at the animals that just have the little bits of thyroid inflammation. We can detect that by measuring thyroglobulin antibody, which we'll go on to talk about. So we can detect the thyroglobulin antibody, but we can see their T4 and TSH levels are okay. And they're slightly older when we get to, well, they're older when we get to the stage that their TSH is high and their T4 is low, when we get that thyroid destruction and the thyroglobulin antibodies are still present. And when the thyroglobulin antibodies have disappeared and we have this atrophic type pathology, then they're slightly older still. So that tells us about the age progression. Now, this is a slow thing. Animals don't become hypothyroid probably over a matter of weeks or possibly even months. It might take years of this pathology spreading or worsening from this very little infiltrate all the way through to here. And given what we said before about how long after complete thyroid failure it might take before we see clinical signs, if we don't see clinical signs until maybe a year after complete thyroid failure, and it's taken us quite some time for that complete thyroid failure to develop, we could have animals with thyroid dysfunction for quite an extended period of time before they're going to present with obvious clinical signs. And then that little group with the high TSH and the normal T4, that's sort of on the way to here, they tend to have an age distribution which is somewhere in between the early thyroiditis and the antibody positive hypothyroidism. So as I say, that may mean that T4 is going to still maintain normal in some of the early stages of thyroid pathology, which might mean we miss some thyroid pathology when we just look at T4. And as part of this pathogenic process, we have antibodies released from that immune lymphoplasmacytic inflammation. And in the dog, the important antibody that's released is thyroglobulin antibody. That can interfere with some of our measurement assays, T3 and T4 assays, causing false results and misleading diagnoses. So when we use thyroglobulin antibody to investigate thyroid in dogs, we're not investigating thyroid function, we're investigating thyroid pathology. It'll tell us whether we've got this inflammation in there, but it won't tell us how bad that is. It won't tell us how much of the thyroid gland has been destroyed. It doesn't tell us anything about thyroid function. When we have followed dogs over time from that earliest stage, we followed a group of 170 for a year, and what we noticed in that time, that 1 in 20 of them became hypothyroid, so emphasizing that this is a slow progressive condition, whereas about 1 in 5 of them had some evidence that their thyroid dysfunction was progressing, and mainly that was because their TSH was starting to increase, even though their T4 was still normal. And some of them, a small percentage of them, their thyroglobulin antibody status went negative, and whether that was some kind of transient thyroiditis, I have no idea, but they didn't become hypothyroid. Maybe they were false positive results. So talking about thyroglobulin antibody leads us on to T3 and T4 cross-reacting antibodies. These are important because they will interfere with our ability to measure the thyroid hormone of interest. We use antibodies in the laboratory to detect thyroid hormones, to measure them, and if the patient brings their own thyroid antibodies to our measurement environment, then we're going to get false results generated. So the main reason to measure T3 and T4 antibodies in a profile would be to know whether or not you could believe the T3 and T4 results that are being generated. How prevalent are these antibodies? Well, if we think about all hypothyroid dogs, about half of them have got thyroglobulin antibody, and that's not a problem. It doesn't necessarily interfere with their assays. But about a third of them have a form of thyroglobulin autoantibody that does cross-react with T3 or T4, and about 15% of all hypothyroid dogs have a form of thyroid hormone antibody which will cross-react with T4, generating false T4 results. These graphics are not the most straightforward to explain, but they result from some work we did a couple of years ago trying to figure out what the impact of thyroid hormone antibodies were on different methods of measuring thyroid hormone. And so we saw that the presence of these T4 autoantibodies in patient serum would cause false increases to be generated in radioimmunoassay and a measurement technique called the emulate veterinary free T4 method. So both of those would give false high numbers when animals had T4 autoantibodies in their serum. A variety of assays gave false low values. So a commonly used emulate canine total T4, a commonly used dry, something called a thermo-dry methodology used in a lot of reference labs around the world now, gives false low values. The in-clinic analyzer, the Catalyst, gives false low values, as does the other in-clinic analyzer, Snapshot total T4. And one that we see in some large veterinary hospitals called a TOSHO gives false low values with T4 autoantibodies. And surprisingly, in this study, even the free T4 by dialysis technique, which we'll talk about later, but which we usually say isn't interfered with by T4 antibodies, did actually seem to generate false low values. There was one particularly concerning assay, which was also using a machine in a reference lab called an Emulate, but it's the human version of their method for measuring total T4. And what that did was it generated a result around the middle of the 20s, like 22, 23 nanomoles per liter, regardless what the real concentration of T4 was in there. So even serum, which we thought had high total T4 values, generated a result of 23, and serum that we thought had low values generated a result of 24. So it didn't matter what the actual concentration of T4 was, the T4 antibodies were interfering with that method in such a way that it just gave results of 20 something. It's very concerning. Okay, so we touched on free T4 there. What is free T4? Well, almost all thyroid hormone is bound to circulating proteins, and only a tiny, tiny fraction is free, around 0.1%, is free in serum, able to enter cells and have a physiologic effect. There are circumstances where we might have reduced protein binding. That might be that the total protein concentration is low, so hypoalbuminemic patients. But it may be a response to non-thyroidal illness. So one of the acute phase protein responses to non-thyroidal illness is for albumin levels to drop. And so when animals are unwell, they adjust both the protein content of their blood, but also there is an impact on the affinity of those proteins for hormone. And when we have reduced protein binding, what that might mean is that although the total result might halve, so in this example here, we've gone from 20 down to 10, the total result might fall very dramatically, but the free T4 result might not change that much. This dialysis technique that I've mentioned involves us putting a patient serum sample in the top of this little chamber. There's a dialysis membrane and some liquid underneath. And the total the T4 that's not bound to anything can come through that membrane, through the gaps in that membrane, and then we can measure the concentration of thyroxine, this free thyroxine that's below that membrane. The advantages of that is it has better specificity. I mentioned before that we get low, free T4 is not as affected by non-thyroidal illness as total T4 is. So medications and non-thyroidal illness might be times when we might think we want to measure free T4 as well as total T4. We didn't used to think it was susceptible from T4 autoantibodies. I'm not sure now whether it is or isn't. The research that we've done suggests it might be. And it's important that if we use a free T4 method, probably we should prefer to use a dialysis or immunoseparation method rather than any of the other types. The disadvantages is that not all the labs do this test, and it's got some manual stages, which makes it more expensive to do. And because it's such a sensitive test to that hormone that's not bound to protein, as the sample deteriorates with shipping, that protein starts to deteriorate and degrade. The thyroid hormone falls off of it, and we start to see a false increase in free T4 concentrations that in animals that, in samples that have been shipborne. And that might take what was a subnormal level high enough to appear to be in the reference interval. These are some charts from a paper at the beginning of the 2000s. They're actually cat charts, but the approach, the same concept applies to dogs and cats. And that is, this is what happens with total T4 when we've got severe non-thyroidal illness. Total T4 becomes subnormal. It's subnormal in quite a few animals with only moderate non-thyroidal illness. But when we look at free T4, and this was using a dialysis technique, there's not, most of the animals with moderate non-thyroidal illness still generate reference range results. And again, most of the animals, even with severe non-thyroidal illness, generate reference range results. There's a much lower number that are subnormal than is the case with total T4. So as was the case for total T4, it's helpful to know what the method is that the laboratory is using and how their results compare with other people's. Generally, the non-dialysis result methods mimic what you would get from a total T4 interpretation. So if your total T4 interpretation comes out low, then probably your non-dialysis free T4 method will do the same. So the dialysis method is more likely to tell you something different than your total T4. So sometimes when people want us to use other types of free T4 methodology, they say, well, there's a good relationship between their method and the dialysis method, and that's to be expected. So in general, if we've got much higher levels of thyroid hormone, that will show up in both dialysis and non-dialysis methods, and we've got very low levels, they'll match in those general terms. But if they matched completely, there would be no point in doing the test, would they? So if a high total T4 was always associated with a high free T4 and a low free T4 was always associated with a low total T4, then why would you do the extra test? Because you get all the information you need from just one test. So that would be this kind of line, this diagonal line up through here where they agree with one another. But sometimes they don't agree. So sometimes we've got a normal free T4 result when we've got low total T4 or a non-dialysis free result. Or we might have a low free T4 but dialysis result when we've actually got a high total. So that would be the general relationship, but it's these discordant boxes that we're interested in when the results are not following the linear relationship, that's going to tell us something extra and useful to know. So our canine non-thyroidal illness group are going to be in here, and some of our T4 autoantibody group, those methods where we got a false increase, are going to be down here. So free T4 dialysis is quite sensitive, and we don't get very many false negatives, but it's not very, free T4, even by the dialysis method, is not quite as sensitive as total T4, but it's much more specific than total T4 is. So we're less likely to get these false positive results. Let's look at a few interpretation examples. Here's Bruin, a dog that sounds like hypothyroidism is a possibility. It's kind of heavy, it's obese, it's got some alopecia. It's itching, which not that many hypothyroid dogs do unless they've got a pyoderma in there. So we look at these results. We've not highlighted any as abnormal. based on some of that sensitivity and specificity stuff that we've talked about, I think we can be pretty convinced that this is not hypothyroidism. So we've got a normal result for total T4, and we've got, it's got reasonable diagnostic sensitivity. And our TSH is normal. That hasn't particularly helped us because it's got good specificity, but it hasn't good sensitivity. But using the combination of T4 and free T4, we looked at some ratios briefly, sensitivity and specificity for ratios. This looks like this can't be hypothyroidism. Also, the thyroglobulin antibody is negative, so there's no evidence of pathology. And because they're negative, we can't have cross-reacting antibodies, which means we can believe these results. These haven't been interfered with by antibodies. Here's a different dog, a low total T4 with a high TSH. And yes, this is hypothyroidism with a high degree of confidence because the high diagnostic specificity of TSH when combined with a low T4. A bearded collie that we know has Addison's disease has been put on an antibiotic for some skin lesions, a trimethoprim sulfadiazine antibiotic. And in this case, we need to be concerned about that antibiotic because this antibiotic can create a reversible temporary hypothyroidism. So if an animal's receiving this type of antibiotic, the sulfa type antibiotics, it's not a good time to test for thyroid function. It's better to wait until those have stopped before testing for thyroid function, because whilst they're in the animal, they are creating a temporary reversible hypothyroidism. So probably this animal's retested after that drug's been taken away, as it was in this case a month later. There's no abnormality there. Here's another dog, overweight, poor hair coat. Total T4 is coming out low. Free T4 using the veterinary method, not the dialysis method, but the Immulate veterinary free T4 method has come out very high. This combination doesn't make sense physiologically, does it? Why would there be such a low total T4, but yet such a high free T4? We've also got TSH is elevated, telling us that the pituitary thinks that the status of the animal is low. It thinks the animal's hypothyroid. It's trying to make more TSH to make its thyroid come to life and work harder. So this combination of results tells us that probably this is an animal with T4 cross-reacting antibodies. The T4 cross-reacting antibodies in this method cause a false high. In this method, they might cause a false low, but this might even be a real low because we've got this high TSH, which is telling it's hypothyroid. Okay, so we've looked at total T4, we've looked at the antibodies, we've looked at free T4. Let's have a quick look at TSH. Again, these combinations of T4 and TSH end up with better sensitivities and better specificities than looking at them just on their own. But we do have this problem where we can have low T4 due to non-thyroidal illness, which will have a normal TSH, or we can have low T4 and a proportion, 15 to 20% of hypothyroid dogs that just don't have that high TSH that we might physiologically expect. So that's the problem that we struggle. But if we add thyroglobulin antibody or free T4 by dialysis in there, that might help us split those types of animals apart. So again, just reminding that if we've got a panel that has got more than just total T4 in it, our confidence levels are really quite high. We can use what we know about how common hypothyroidism is in the samples that people are taking to give us a range of predictive values using the sensitivities and specificities that have been published. So this, again, some quite old data, but it said that of all the thousands, this was a data set of 143,000 thyroid profiles that came into Michigan State during this 2-year period. And most of them, 67% of them, looked like the animals were euthyroid. They did not have hypothyroidism. About 8% did have hypothyroidism, and half of those were thyroid globulin antibody positive, fitting with thyroiditis, and the other half were thyroid globulin antibody negative. And then there's a group, a tedious group of around 17%, where we can't be sure whether they were hypothyroid or not. These were largely the group that had low T4 but normal TSH. So the prevalence of hypothyroidism in this group is somewhere between the 8 that we can definitely see and 8 plus 17, which would be around 25. So somewhere between 8 and 25%. So let's round those numbers up a little bit. Look at total T4 on its own. In this range, 10 to 25%. Positive predictive values not great, 28 to 54%. Negative predictive value is brilliant. So if both total T4 and TSH are normal, hypothyroidism is very unlikely. And using the combination of T4 and TSH together, our positive predictive value is much increased here to 83 or 94%. All right, another quick example. It's a poodle, superficial pyoderma. Total T4 has been measured on its own, a result of 34. Do we keep thinking about hypothyroidism in this dog? Are we going to put it on medication for thyroid disease? So I think most people, honestly, looking at this for the very first time without what we've just discussed in the last few slides, would just say, yeah, that's probably not hypothyroidism. We can move on and look somewhere else. But if the initial panel had not just been a total T4, but been a total T4 and a TSH, and we had this result, then I think right from the beginning, we'd be very much more suspicious that something is going on. These two results don't fit with one another. So why is that? Why is this pituitary making so much TSH if there's this much T4 being made? And then we add some other results. So if, for example, we had a thyroid globulin antibody in here, then we'd go, aha, that's what's going on. We've got evidence of thyroid pathology. The TSH is high, so that even the pituitary gland is recognizing we've got a problem here. And so then we can find an explanation for why our T4 looks so high. It's because some of these thyroid globulin antibodies are cross-reacting with T4. And now, with a very low free T4 result and a high TSH and the evidence of pathology, we can be really confident that this is hypothyroidism due to thyroiditis, which is very different from the starting point of 34. We can also use T4 in particular when we're looking at animals that are on thyroid therapy in terms of the adequacy of treatment and whether or not we can expect good response to therapy. But not all thyroid hormone products are the same. They all have this similar sort of profile, though. They have peak absorbance around 2 hours and then a half-life kind of around 10 hours, something like that. And so if you're sampling an animal to see whether or not you've got good thyroid hormone concentrations, it's going to be really important that you know what time since the administration of the tablet was that you're sampling the animal. Because a result somewhere slightly above the reference interval at 2 hours post-pill is probably good, but if we had that result at 12 hours post-pill, then that would be that the animal would be getting too much. And similarly, if we had a result somewhere around here at 12 hours post-pill, then that's probably good therapy. But if it was at that level at 2 hours post-pill, then it would be inadequate therapy. So we can't just take a sample at any time point and interpret it without knowing what that sample time point is in thyroid therapy. Also makes a difference whether the animals are being fed or not with their tablets. So giving thyroid hormone with food results in about a 50% reduction in its absorption. And that's not really a problem as far as the animal's concerned, so long as the owners are always doing it the same way all the time. And so long as when you sample it for monitoring, it's getting treated in the same way that it normally would. So if it normally gets its thyroid hormone with food, then it should get its thyroid hormone with food on the day that you're sampling it to see what the levels are like. It's also worth recognizing that if thyroid hormone therapy is adequate, it should, through negative feedback, be shutting down TSH. So we can use TSH as a bit of a compliance monitoring tool, as well as total T4 levels. Total T4 levels are just telling us what happened with that last dose of medication. Maybe the animal spat that particular last dose out, or maybe the owner's given that last dose, but they haven't been giving the medication in the weeks before. TSH will help us understand what's going on if we add that in our monitoring panels. Here's some experimental animals that were hypothyroid, which had their thyroid hormone medication stopped over a course of days. Each of these dots here is a different day. And we can see their medication stops, their thyroid hormone concentrations fall. You can see it can take a little while for the TSH levels to start to increase. So TSH gives us a longer evaluation of adequacy of thyroid therapy. It tells us what's been happening in the previous days rather than the previous hours. And similarly, when we put the animal back on medication, their T4 levels start to come back up and their TSH falls, but it takes a few days to fall back into the reference interval. So we can use TSH a bit like how we would use fructosamine for diabetics. It gives us an overall view of what's going on. So we're still on hypothyroidism, but we're going to talk about cats briefly. Here is a hypothyroid cat, weight gain and seborrhea. And hopefully the quality of the image is good enough. You can actually see the skin flakes on the hair coat of this cat, very seborrheic. And that seems to be their presentation. So yes, they get weight gain, lethargy, if that could be identified in a cat, but that's seborrhea. They don't necessarily get really obvious alopecia or some of the other things we might be expecting from a dog. And the canine TSH assay that many labs use does seem to work to a large degree for cats. And so, yeah, this classic picture, that same cat, low total T4, high TSH, just as it would do if it was a dog. And we get the same thing after this is a cat after thyroidectomy, pre-surgery, and then 6 months later, it still hasn't been able to regenerate any thyroid tissue. What's been taken out is all that it had, and it's not been able to, even these very high TSH outputs haven't been able to stimulate any other thyroid tissue to come into action. So this animal is biologically hypothyroid. And there has been work done both by Williams and Mark Peterson demonstrated that T4 and TSH levels can be prognostic for therapeutic response when we're treating hyperthyroid cats. If we make them hypothyroid in that process, then our chances of survival are very much reduced. This was a series of cats I looked at many years ago where we compared their total T4 results with their TSH values, and we could see that once we got to total T4 values that became subnormal, around 70% of them had high TSHs, which is kind of similar to the diagnostic specificity of this test in the dog. So it seems like that technology does work for cats. It's not perfect. And it has been used to identify decreases in both hyperthyroidism in cats and in non-thyroidal illness in cats. So yeah, let's skip on to hyperthyroidism. Don't have a lot to talk about here. But these, again, some charts from Mark Peterson's work looking at a comparison between total T4 and free T4. So we've talked a little bit about the advantages of free T4 already. And what this helps us recognize is, although some of our hyperthyroid total T4 cats have got results in the reference range, even down towards the bottom end a little bit, that's less likely to happen to free T4. Also, that when we've got other illnesses, total T4 will often drop below the reference interval, but free T4 by dialysis will not. We've also got a really good example here as to why free T4 by dialysis can't be used as the main single test for hyperthyroidism in cats. And that's because it's got quite a reasonable false positive rate. So cats with other illnesses might have high total T4s. Sorry, might have high free T4 by dialysis. When we're looking at mild or equivocal hyperthyroidism, where the total T4 values are sort of borderline, so in this group of hyperthyroid cats, we've got borderline total T4 values, some of which are within the reference interval. That same group of cats are much more likely to have increased free T4 by dialysis results, helping us confirm the diagnosis. So free T4 by dialysis is particularly helpful for our high normal total T4 cats where we think hyperthyroidism is still likely. We looked at this earlier, and this may be slightly moving out of hypo and hyperthyroidism. This is just non-thyroidal illness, and actually total T4 is a really good way of identifying the severity of illness, and it has a really strong correlation, particularly in cats, with prognosis. So no matter why the animal's unwell, the lower the total T4 value is, the less good the prognosis. And that has also more recently been shown by Mark Peterson and colleagues to be a similar impact or effect with measuring TSH. So not just measuring T4, but measuring TSH as well. Both of those have a correlation. The lower they go, the worse the prognosis. So kind of taking some of what we've looked at there in terms of what the effect of non-thyroidal illness would be normally expected. Here's a couple of cases, very similar, PUPD, inappetence, weight loss, both with urea, creatinine, and phosphate parameters that suggest that there's a significant degree of renal dysfunction. In one case, we've got a low total T4, and in the other, we've got a normal total T4. So have we ruled out hyperthyroidism in both of these cases? Well, I would say not. I would say this case B is very likely to be hyperthyroid, because we're kind of expecting a cat that's this unwell with chronic kidney disease. The response that most cats are going to make to that degree of illness is to lower total T4 levels. And this cat B hasn't done that, which suggests there is a drive or an autonomous drive to continue to make T4 despite the presence of the non-thyroidal illness. And so whilst this might not be above the reference interval, it's inappropriate given the degree of illness. So that comes back to us thinking about negative feedback and what we expect thyroid hormone concentrations or any hormone concentrations to be given a particular physiologic circumstance. So when we've got an animal that is very unwell, we're expecting low T4 if it's got normal thyroid function. If it's not low, it is suggesting that we might have hyperthyroidism. So we can combine some of what we've just talked about into a little chart like this. If our total T4 is less than around 30, this is all going to be subject to your own laboratory results and how you trust them and how you get used to working with them. But in the labs I've worked in, a total T4 less than around 30 is likely to be not a hyperthyroid cat. And a total T4 more than 60 is a hyperthyroid cat. But cats with total T4 in this upper part of the reference interval, we can split those apart by measuring free T4 by dialysis, because if that's normal, they're not hyperthyroid, and if that's high, they are. So free T4 dialysis is a particular place in cat hyperthyroidism diagnosis in these top half of the reference interval total T4 cases. So just looking back, we looked at this chart already when we were talking about dog hypothyroidism, but just reminding ourselves that this is the concern that we have with the different free T4 methods. If it's a dialysis method, we might expect the result to be high, even when the total T4 result is normal, or the other free T4 method that's not dialysis might be normal. This is some data from Imulite free T4 method versus a dialysis method, and we can see that whilst there's a relationship, you could see there's going to be a lot of discordancy here, and the discordancy is what we're interested in. That's why it's useful to do the test. So hopefully what we've conveyed in this session is that the diagnostic tests for thyroid disease are not perfect. A standalone total T4 on its own has got limited value. Combinations of tests, total T4 and TSH in particular, really improve our confidence for hypothyroidism in the dog, and we get even more confidence if we've got thyroglobulin antibody in that panel. We should recognize that different methods are going to give different thyroid hormone results, and also we should know that different methods have different responses to this thyroid hormone, sort of T4 autoantibody or cross-reacting thyroid hormone version of thyroglobulin antibody. And we might need free T4 in the cases where our total T4 and TSH in the dog haven't confirmed hypothyroidism. Free T4 dialysis might help, and it might also help in our cats that have got that high-end normal total T4 value. So hopefully I've conveyed something useful to you. If you needed to get in contact with me in the future, this is my email address.